Okay, well, welcome everybody. As you can see here, I guess it was on, is our QR code for our survey. So please take a minute and fill out that survey, letting us know kind of what you want to have discussion topics on. Really helps us to kind of find faculty who can give specialized expertise advice on those topics. So just let us know, and we're happy to go out and get some people to talk. So it's my pleasure to introduce Christine Dorman. She's a distinguished nurse practitioner who works with me and specializes in wound ostomy continence patients. Christine's journey in nursing really began in 1984 at MSK, where she developed a deep passion for ostomy care, and this is one that really continues to drive her work today. With 40 years of nursing experience, Christine has made a significant impact not only on as a clinician, but also as an educator and a researcher. She's mentored and precepted numerous nurse practitioners in wound care, ostomy nurse students, sharing her expertise as an adjunct professor at Stony Brook University and as a provider in a primary care on Long Island. Her commitment to advancing ostomy care really extends beyond the bedside in the clinic. In 2020, she earned her Doctor's of Nursing Practice degree from Stony Brook and has contributed to research aimed at improving ostomy outcomes in patients. She conducted several studies, but one is a retrospective study at MSK identifying the rates and risk factors for peristomal hernia formation, and she's currently leading a practice improvement project focusing on non-surgical interventions. So today we're really fortunate to learn from a real expert about all of her vast knowledge and expertise. So please join me in welcoming Christine Dorman.
Thank you. Thank you very much. I'm very excited to be here. I will share my screen, I hope. Okay, so the struggle is real. Ostomy situations could be simple or pretty problematic. And when I was thinking of what we could talk about today, I wanted to discuss marking, stoma types, pouching systems with accessories. We try not to call them appliances anymore because it sounds like a refrigerator. So we try and say pouching systems in New York City, at least, and the WOC, which is the Wound Ostomy Continence Society. Immediate and long-term post-op complications, the treatments that we at Memorial use for those problems, and quickly peristomal hernias, of course, because that's what I love to talk about. So as you folks know better than me, colorectal cancer is probably, I think, the third leading cancer in the world. And in the past 2 decades, increase in young adults with colorectal cancer has been occurring. And Memorial Sloan Kettering, I think about 5 or 6 years ago, started a center for young adults with colorectal cancer to try and figure out what's going on, why young folks are winding up with cancer. And I don't think we have a rationale yet. These are the usual statistics that we always see, how many people in America live with ostomies. But the one I wanted to mention was there are about 200 ostomy surgeries that occur at Memorial yearly. And that doesn't include GYN and maybe gastric mixed tumors, hepatobiliary. So why do we need to stoma mark? So this is a Memorial Sloan Kettering patient who is lying down post-op, a while post-op, and this is what she looks like sitting up. And so here's another photo of someone's skin folds and skin damage related to leakage. And this last one was a GYN patient, and we actually used her to speak with the GYN surgeons about 8-9 years ago to convince them that they need to send their patients to us to get pre-op marked. And this patient, the last photo, wound up going back to the hospital, being admitted, and excuse me, she needed morphine for pain control. So that gained us some respect from the GYN folks. And here are a few other examples of skin folds that could have possibly been avoided if the patient was pre-op marked. So one thing I wanted to talk about was that I'm sure you folks know that the Wound Ostomy Continence Society, the American Urostomy Association, and the American Society, I think it is, for colorectal surgeons, have a position statement that talks about pre-op stoma marking. And it says that patients who are having pre-op surgery for any ostomy should be marked by a trained clinician. But for you folks who don't have wound ostomy continence nurses in your facility, this link gives you some information about it, about the statement. What is it called? Position statement. And then I don't know if you know that the patients have a Bill of Rights for ostomy care. So patients know about this, many of them, especially because of the internet. And it basically says that the patients have a right to be marked by someone pre-op and be involved in their care pre-op and post-op, and then for the lifespan, to have someone who knows enough about ostomies and ostomy care to take care of them. So I just wanted to let you know, and the links talk about the Bill of Rights. So how do we stoma mark a patient? We need, obviously, you need to know the patient's history. This consent should be signed before any ostomy nurse will mark a patient, but at least the consent should be discussed with the patient so they know what's going on. Abdomen gets assessed in multiple positions: standing, lying, bending, sitting. And we notice the rectus muscle, the strength of it, the umbilicus, the bony structures, the hips and the ribs, any scars, and in our field, patients with hepatic pumps. And then we have to consider patients' occupations. Police officers, firefighters, they carry a lot of utilities, right? So they need their guns or their belt that has a lot of instruments on it. So we try and consider that. And then we think about patients who have strokes or anomalies that they can't use their hands or their vision. Different types of ostomies. They're the basic, and it usually shows you the location where they'll be, but you know that already. And then the other thing we keep in mind is with our extensive radical surgeries, we have to consider, is plastic surgery involved? Are they borrowing some of the rectus muscle? What will they use as a flap? And if they borrow any muscle on the abdomen, it causes problems for us, because if somebody is being marked on either side and a piece of the puzzle is removed, when they pull this medially, the mark could wind up right in the middle of their abdomen, which isn't favorable. So this is what to avoid: scars, dips, consider patient circumstances. And the supplies that you need would be a marker that's a surgical marker. We usually use alcohol wipes to clean the skin first, and then a transparent dressing of some kind. At Memorial, we have stickers specific for surgical marking. So we know that all abdomens are not created equal, and we have an epidemic of obesity in America. So marking isn't so easy. And if you notice, no one looks like this fella over here. Most women have multiple bulges and skin folds. Men with pot bellies, I'll put it bluntly, they lose their line of sight when you're trying to mark them. So this is instructions on how to mark a patient, and the handouts, I think there's a link in this presentation. So we always have to look at the patient standing, sitting. They have to be able to see where they're being marked, or else they can't take care of themselves. We try and mark the patient within the abdominal rectus muscle, but I'll tell you from my study, out of the 22 patients who had hernias, 20 of them were marked within the abdominal rectus muscle, and that's pretty equivalent to what the research shows. We avoid the skin folds. Women's bodies and men's bodies are different. When women sit down, they usually abdominal folds around their umbilicus. Men usually have abdominal fold above or below, and their umbilicus is where we usually wind up marking them lateral to it, whereas women, we could do it on the abdominal bulge below it. So this is a patient I was trying to mark, and you could see this is a little lateral, but the purpose of these photos is so you could see the difference in positions. So this is her sitting, didn't look so bad, but when she stood up, her pannus fell. And this gentleman, I thought I was in good shape with either spot, but when he sat down, his lower spot is actually in his pelvis, so that wasn't usable. And these are a few other examples of what people look like when they're sitting and standing, and with a lot of skin folds. This is a simple scar to avoid, but some people have very bad scars. And then when we mark patients for two stomas, a urostomy or a colostomy, we try and have one higher than the other. And usually urologists want their mark lower, but as you could see, this man, if I went any lower, it would be right in a skin fold. So it's a little tricky. And then when plastics is involved, we try and do a mark lateral to wherever we're picking, about 4.5 centimeters more lateral. And this patient, I don't remember the patients, it's been so long, but this patient, I was probably told, put 4 quadrants, so they got this many marks because plastics was involved. And then that's just another example when people sit down, and women especially, the midriff bulge separates into 2. So stoma characteristics. We have protruding stomas, flush stomas, recessed stomas, and my coworkers wanted me to let you know that no matter what anyone ever tells you, patients or other surgeons, we never want a flush stoma. Flush stomas almost 100% cause us difficulties. So we always ask for a protruding stoma. This stoma is, this side is the better amount of protrusion than this lower portion. So os location matters, which it's difficult because when you create the stoma, they're swollen, and as they shrink, or if there's a suture that pops, it switches the position of the stoma. So this patient's having a lot of difficulty because the os is here, this os is in a skin fold, this os is at skin level, and it's creating the skin damage. So pouching systems, what do we talk about? When I first started at Memorial, there were very few choices. This is called a Bongard bag, and that's a rubber band. Patients would have a barrier. You would cut the right amount out to match the size of the stoma. You would match it with this product, attach the 2, and then use a rubber band at the end to close up the pouching system. And they also had what was called, and is still called, stoma adhesive, which was actually taken from an oral paste that dentists use. And then Squibb and Sons also worked with Convatec. I don't know who bought who, but that's how Convatec wound up with stoma adhesive barriers. So now we have many options. We have flat products, we have convex products, we have one-piece products, and we have two-piece products. There's urostomy spouts and leg bags and high output pouches and fistula pouches. They come in different sizes, different shapes. And we also have ostomy accessories. These barrier rings have made life much better for patients and for the wound ostomy continence team. Convex products have really made a difference in the care. They have adhesive remover spray. I don't know if you know that, but even if someone has a wound vac, this works wonders. Any of the company's brand. Patients are encouraged to wear belts if they want to, but sometimes I tell patients that the belt is part of their pouching system. Deodorant lubricants, they have plastic guards for people who have physical jobs or physical contact where they want to protect their ostomy if they play sports. They have different types of belts, support garments. We'll do that later. Post-op complications, stoma necrosis, and depending upon how much of the stoma is necrosing and sloughs off will determine how difficult it will be to pouch a patient. So this is a urostomy. Many times when a lot of stoma is sloughed off, we have a stenosis in the long run. Mucocutaneous separation, stoma swollen, patient's abdomen is distended, and the sutures pop and they leave us with wounds to deal with. The simplest immediate post-op problems are the skin damage. So number one is moist. Nursing has their own terminology. The Wound Ostomy Continence Society, MASD, is moisture-associated skin damage. It's irritant contact dermatitis, right? So the skin, epidermal skin is lost. Note where the os is. The second example is a fungal rash, the small little dots and sometimes tiny whiteheads, telltale sign. Sometimes fungal rash is so bad that it's moist and it's painful, and that's what it looks like. Maceration is almost always a gray color. It could be from urine, this is a urostomy, or it could be from stool. And then folliculitis, patients wind up with folliculitis. But for me, that is one of the least common skin issues that we wind up with. And number 5 is pyoderma, which is painful for patients and could be very challenging to get under control. At Memorial, we send them to dermatology sometimes. Dr. Markova is a dermatologist who's willing to work with our patients, but she gives patients injections, and many of them tell me that that hurts, the steroid injection. So I'll move forward and we'll talk about what we do for them. My tools of the trade and what I use almost every day at work is silver nitrate, the hydrocolloid dressing. I don't know if you know it. We have hydrofibers, and the most common one we have is Aquacel at Memorial. It absorbs drainage, and this one is so nice. It comes in a little ribbon shape, so we could use that easily. Antifungal powder. This has been a game changer for us because up until one of the Wound Ostomy Continence Society members mentioned that they use steroid liquid steroid like Nasonex or Flonase, patients would have to get prescriptions from dermatologists and they would forever order creams without understanding that it does not allow the product to adhere. Stoma adhesive paste is just common paste that powder we use to sprinkle on irritated skin, epidermal skin loss to absorb some moisture. And I use steroid ointment on, say, peristomal wound ulcers that could either be from pyoderma or for whatever reason, no one knows, sometimes pressure, but I put it under the hydrocolloid dressing. So there's an ability for it to adhere. And it's on an ulcer, which is usually smaller than the whole area. So another peristomal early post-op complication, occasionally, this doesn't happen often, people will get superficial abscess at the suture line site. So what do? We express the pus, and then we do the treatment of a hydrocolloid dressing, put the product on, and don't use a convex wafer. It puts pressure there if possible, and then it heals. And this was my mother-in-law. Out of all the patients who I see never get this, my mother-in-law got it. So these are some situations that we've seen. And long-term complications could also be short-term complications and vice versa. The other thing that we see a lot are granulomas or hypergranulation tissue and contact dermatitis. So this lovely lady was having trouble keeping her product on because it wouldn't adhere anymore. So she kept putting more tape on further out. So this is adhesive related. But the other thing she was doing was cutting the opening too large, and stool kept leaking below the ostomy product, and she wound up with hypergranulation tissue. And what most patients will do is cut the product opening larger because those hurt and they can't get a good seal, so they include it in the opening, which potentially worsens the problem. This patient had an excision by Dr. Patey, and after getting Nasonex and the right size product, this is what her skin looked like when she came to see me. Oh, but her stoma eventually wound up stenosing to this tiny little stoma, and it created almost an obstruction, and she needed a diverting ostomy on the other side. So ileostomy drainage is more caustic and a lot more problematic than colostomy drainage. These photos are just this is a repeat, but to show you what happens in a short amount of time. And this photo is to show you that sometimes patients can't differentiate between their stoma and irritated skin. So they keep making the opening in the product too large, and it just continues with the problem. And so that's actually the size of the stoma. So what do? We always have to figure out what's causing the skin alteration. Many times, and most times, it will be leaking. And this is a hydrocolloid dressing that I'm putting over the most moist area because otherwise the product won't stay on, and it just is a vicious cycle. It leaks, it won't stick, it leaks worse, it won't stick. And treat the patient with an antifungal powder and it resolves. And this again is the hydrocolloid dressing that isolates the stoma, and then we put a barrier ring around it, and then the product with a belt. So this patient had almost all of it: maceration, fungal rash, adhesive-related skin injury, which they call MARSI. Down here, they rip the product off and they rip off a layer of skin. So in case this was contact dermatitis, which I think it was, it's so long ago, I treat the patient with antifungal because most of the time there's a fungal component, protect the skin with the hydrocolloid dressing, separate it from the product that the patient's using, and pouch it with the barrier ring and the pouching system. This patient was sent to me in the office where I work as a primary care nurse practitioner. I have no idea who sent me them or how they found out I existed, but obviously this was a large, the patient was probably in his 40s, but he had a large belly. He had 2 stomas. I don't even recall why. Retention sutures. Nobody knew how to take care of this, but I packed this with the ribbon Aquacel. This little area also, I covered it with the hydrocolloid dressing. I isolated the stoma. When he came back to me 2 weeks later, you could see how this part has started granulating in and this part lost most of its depth. So I just used hydrocolloid here without the ribbon dressing, and this one I repeated it. Patient never came back to me, so I'm assuming they did okay, I hope. So here's a mucocutaneous separation, and this is just silly, but what do we pack it with? The hydrofiber and Aquacil. What do we cover that whole wound with? A hydrocolloid dressing. And then we apply the pouching system, preferably without convexity or light convexity. And this is just more examples of the hypergranulation tissue. Patients cut the opening too large. I always try and use lidocaine gel. I put lidocaine gel, then I use silver nitrate sticks, repeated treatments every 2 weeks, every 3 weeks, but they have to have the proper pouching system. And this is what they look like when they heal. And this is another patient who came to see me in the office, not at Memorial. And in that office, I would see 30 patients and no one's simple. So he had to wait. So on this trip, he said, I'm not coming back to you. It's good. So he never came back. I don't know what happened to him. But you could see just silver nitrate stick and proper pouching system and hydrocolloid dressing. And this is a patient who came to see me with pyoderma. And when they're patients who aren't Memorial Sloan Kettering patients, and they only have ostomies because of a non-cancer, non-chemo type of situation, I'm not shy to order oral steroids for a little while. So this man came to see me. This was a wound, his pyoderma. So, I sent him to get it diagnosed by the derm, and I gave him oral steroids, and we used what we talked about, the little dressing and then the hydrocolloid, and then it healed. Long-term complications, prolapse. And I'm sure you've all seen prolapses, but they're not great for the patient and they're not great for us, because if it's an endostomy that's prolapsing and we try and put a binder on it, if you don't make an opening in the binder to pull that pouch through or to try and leave space for the stool to go into the pouch, it pancakes, it just flattens out and leaks. So it's challenging for these patients. And over here, there's a little bit of necrosis, but every now and then we get a patient whose prolapse is necrotic and they need to go to surgery right away. We try and reduce them in the clinic. Sometimes not often do I have to use sugar, but sometimes I have to. And the education to the patient is don't leave it out. Lie down in bed and try and reduce it yourself and wear the binder. And if it doesn't work, come back and let us see what we could do to help. This was another patient. That's a 4-inch wafer and pouch. So that's a pretty big prolapse. It's a double lumen. They're my least favorite to work with because I can't solve the problem for the patients. So these are ordinary binders. I usually cut them in half lengthwise, put them on while patient's lying down after I reduce the prolapse. And then if it's a loop, one of them is prolapsing sometimes, and hopefully it's the non-functioning one. So I could cover that and the other one will be open and the stool will flow, but it's iffy. This is a New Hope hernia belt. It is pretty much the gold standard that we have from when I was a new ostomy nurse. It's the same thing. And they make this hokey little flap that's supposed to go over the prolapse. Doesn't work often. Stenotic stomas and a long-term outcome could also be recurrence. And the avulsion wound. This is one of the wounds that I see a lot, especially with obese patients and patients with peristomal hernias. This was a patient, oops, this was a patient of mine. And when I tried to have a private practice, then I found out very quickly it wasn't successful financially for me. But her stoma, her peristomal hernia was so huge that her urostomy just pointed down to her foot, and she was too chubby and too old to be able to put it in a binder. And this wound just came. And this person's wound, it's just actually, it just rips open. And I try and treat them the same way I treat the other wounds. Sometimes I'll send the patient back to the surgeon to maybe get rid of that piece of tissue so that it will heal better. And here's another one. This one would be easier to treat because it's just ripped away from the stoma, and I could treat it with the hydrocolloid and the hydrofiber ribbon. But the takeaway is these wounds usually happen with obese or peristomal hernia patients. Chemotherapy sometimes is not our friend. This lady was had her surgery outside hospital. She had 2 healed incisions when she came to see me alongside that stoma. And after she started chemo, this side opened and then this side opened. Peristomal hernias. This man somehow found me in Long Island at that little office. And this is what he looked like when he first came to see me. He was almost died in a local hospital. He has a huge defect that healed. He has an incisional hernia and he had a peristomal hernia, and he was in his late 70s, and so was his wife, and she was the one taking care of him. And it was awful because then his stoma prolapsed, his hernias got bigger. It was almost unmanageable for this woman, and she just said she's wrapping him and his product under tons of paper towels. But terrible, right? So when I did my retrospective review, I looked through a lot of charts, but I only got 78 patients that fit the criteria. And out of 78 of the patients, 22 had hernias. So that's 28%. And like I told you before, 20 of those 22 had their stoma site marked in the rectus muscle. The significant findings I had were with the univariate analysis, it was obesity, diabetes, and multiple abdominal surgeries. And then the multivariant, it was just abdominal surgeries and diabetes. And those were my 2 risk factors that came out. Excuse me. But what also came out of that study was that we could fight for some nurse practitioner in the clinic so that there would be some provider dedicated to following up these patients and trying to figure out how to prevent peristomal hernias, and to be there, as the Bill of Rights says, to follow them through their lifetime. So that position got made after we were able to say that 53% of our patients could have been seen by an NP and been billed. So that's how my position got made a year and a half ago. This gentleman had the largest peristomal hernia I've ever seen, but he also had a collagen deficiency. And these are just other examples of patients who suffered because of their hernias. And this is the support garment that is by New Hope. Patients get measured for this support garment, and the opening will suit whatever product they're using. They get measured by the ostomy team. Other countries have support clothing, and the UK is where a lot of the studies that were getting done by nursing in the early 2000s, that's where I grabbed my data from, because we had none in America at that time. Since then, a lot of studies have been done to try and figure out what to do. This is when a patient has a urostomy and a colostomy, they need to be measured for the support garment. And I also, in my study, 27% of the patients, when I looked at that data were lost to follow up at Memorial Sloan Kettering. So that was another piece that allowed us to fight for my position. So now what we're doing is we're educating the patient to their risk factors, and colostomies have a higher rate of peristomal hernia, obese people, people who cough from COPD or asthma or smoking. There are core abdominal core exercises that we hand them a sheet and we practice, tell them to practice, and then we put them in the white temporary binder because most people hate binders, and I have to see if they're willing to wear it. And then we measure them for a binder, or we give them options for support garments. And the key is for them to come back and be seen not in 4 years or not after the bulge has occurred, but prior to that. And you folks know better than I do that after they have their peristomal hernia repaired, there's a 50% or greater recurrence rate. And I don't want to not talk about perineal hernias, but patients wind up sometimes with perineal hernias, and we have nothing for that. I tell them to use bike shorts or Spanx or panty girdles, but in essence, we really don't have anything to help them yet. And one of the future studies before I retire will be a little retrospective review to see how many of our patients at Memorial wind up with a perineal hernia. So Memorial Sloan Kettering WOCN nurses want to thank you and your team members for your interest caring for these patients. They suffer physically, emotionally, psychologically, spiritually, and financially because of the treatments and surgeries and what we do to them to help them survive. So
That's great. Thank you so much for the presentation. It's always really helpful to kind of see the, honestly, the worst case stomas and then to kind of recognize the problems from there because the nuances about peristomal pathology is difficult.
oh yeah.
Yeah.
So I have a couple little show and tell items.
Hmm.
So is that it's going to be backwards
Yeah,
for
yeah,
you,
that's
but
the
this is the ribbon, and we cut it and we pack small areas. And if you know that the Aquacel comes in squares, big squares, small rectangles, a convex product looks like this, and all convexity isn't created equal. So this is a convex product and this is a convex product. And if you could see, their heights are different. And this company became famous because it has a lip that you put your thumb on to snap the pouch. It's a great company, but for me, sometimes their convexity isn't deep enough. This company could solve 94% of my problems at Memorial, but they don't have any funky little snapping. You have to snap the pouch on the patient. And the other problem with this is it's very rigid. So if you remember some of those skin folds you saw, this product has nice deep convexity. It's called Marlin. It's an outlier. Most people won't ever know it exists, but it fills in those skin folds and the patients wear it with a belt. And now they have these little, instead of using tape like years ago, you put your pouching system on and then you put these on to help secure it. And this is the, if you guys ever try and use this, if you want it flush against the stoma, this is the hydrocolloid dressing, cut a little smile in it so it goes flush against the stoma. So I think unless you have specific question, oh, this is a godsend. It's the adhesive remover. Steal it, find it. If you have wound vacs, just put it in your pocket and just bring it around with you. Questions?
the hydrocolloid dressing that's not the ribbon. I didn't know about that. I'd seen lots of kind of peristomal separations that I had packed with Aquacel as a resident. But then had horrible tr luck trying to get the pouch to seal around it. So that's really helpful
So
to know.
anything wet, you know it won't seal.
And
Anything, the skin will never, it will never accept the adhesive. And these Band-Aid brand makes them, but they're smaller, but they make extra large size. And sometimes they have even rectangle ones in drugstores. So when the patients are panicking and we call them on the phone, go to your local drugstore and get the blister Band-Aid hydrocolloid dressing and then come see us. So those are like my main staples of care that solve a lot of the problems. But the liquid steroid, the Nasonex, game
Right.
changer.
So one question that has come up was the hydrocolloid ribbon dressing. So if you have an abscess or a separation and you're packing that, how long do you leave it in place for?
This little guy,
Yes,
the
how long do
ribbon.
you change the bag? Just some general wound care with that would be helpful.
So all hydrofibers and alginates could stay in for 2 to 3 days.
Oh,
So this is an alginate or a hydrofiber, and their job, they look like felt, if anyone remembers felt from being a child. They look like felt, but their job is to absorb a lot of fluid. So we use them for dressings and wounds, but they come in ribbons for packing and they come in sheets, but they're perfect for the mucocutaneous separation. And this way, the patient doesn't have to change their pouching system daily. It could be every other day or every 3 days. So hydrofibers and alginates, they look like felt. Their job is to absorb and they could stay on for at least 2 days.
very cool. Very cool. I actually personally had a question. I've had probably 3 or 4 patients come in with bad prolapsed ostomies, and I noticed your picture and on your PowerPoint. There were some small areas that looked like you'd use silver nitrate on them. Are you what?
Necrotic, necrosis.
Oh,
That's the
so
starts of necrosis.
what are some tips that you have about like peristomal varices or bleeding, or how would you recommend treating these patients so we don't even get to a point where it's, massive bleeding? So,
So the peristomal varices, they're tricky because they're usually from portal hypertension related to cirrhosis or
mm,
liver mets. What we do is it would have to be a non-convex product, a flat product. And when they're bleeding, someone usually has to take them and do a embolization or something. We don't have any treatments for
mhm,
that. The only thing that I would ever possibly suggest would be neosynephrine for a temporary relief to get somewhere because it's epinephrine
mhm,
and it might constrict the vessels, but we don't have anything good. If someone was actively bleeding, you could use a sheet of this,
mm,
right? If they were trickling a little bit and not needing to go to an emergency, you could use a sheet of this underneath wherever the vessel is or the bleeding is and gently put something over a flat, non-convex product like this
yeah.
guy, flexible, but
Yeah, I generally find that even in patients who don't have portal hypertension, sometimes they're not varices per se, but even the irritation from chronic prolapse will cause this like slow ostomy bleed.
then
Um,
I would silver nitrate it.
yeah, it's okay to silver nitrate
If it's
the
just
system.
from ostomy, yeah,
Yeah,
silver nitrated, neosynephrine. But
that's a good thought.
usually we
Yeah.
call you guys when they're bleeding because, there's only
Yeah,
so much we could do there.
right. I guess maybe just proper compliance with a abdominal binder that will work for a prolapse will kind of prevent, and maybe a little prevention to make sure
Give
they
me
don't
a
have.
peristomal hernia any day over prolapse because those
Yeah,
those support garments have to be put on while the patient's lying down and the hernia is recessed to gravity into their spine area. So they put it on flat, but the minute you stand up or cough with your prolapse, unless you're holding it with your hand or half of an opening in a binder,
yeah,
it
it's hard to
pops right
do.
out.
And some of these patients are just not surgical candidates for revisionary procedures, so totally get that.
So then we get to the emotional, psychological, and physical trauma that they have.
Yeah, yeah, it's a whole mix.
I had a quick question. Well, I had two questions, but one of the things that we were talking about kind of offline is sometimes we have patients who are peritonitic and getting an emergency stoma, and I think sometimes it's difficult for them to do all the maneuvers to sit and stand and do a little abdominal crunch. Usually, what I try to do is get a sense of like at least where they wear their pants, at least the creases, and can they see the where I'm marking. But it's hard especially when they're in so much pain, to kind of get like a detailed exam? I don't know if you have any advice for that.
So, you know, so many people when they're emergent, they have a distended abdomen. So it's really hard
Right.
to tell.
Uh,
And I would try and remember that women usually have a line bisecting them right across the umbilicus,
okay.
but men usually have about this much space around the umbilicus that will be a bulge.
Okay.
So women, like that photo, there was a nice
Yeah.
crease midriff, and men usually, so you would want to go below the belly button for a woman
Yeah.
most of the time, and men alongside it, lateral
Okay.
to it.
Mm.
But I always try and when someone's lying down, a few times when I was in the hospital that I was called, I try and put their head up so I could see the skin folds, or pinch
Yeah.
their abdomen around
Yeah.
the, you know, like 4 inches, two above and two below the umbilicus to see where possibly the skin folds would be.
Yeah. That makes sense. Those are good tips as well.
Yeah.
And then one of my other questions, and I'm sure that you kind of touched on this, is I think as we're taking care of patients that are further away from like our tertiary care hospitals, there's like phone calls and then weekends if they're having troubleshooting issues. Like, what are some of the things that you say over the phone that can kind of get them through 24 hours until they can kind of come see you back in clinic? I think you touched on that a little bit earlier as like, what does the drugstore have? Like, what can you do at home to temporize?
The hydrocolloid dressing, because a lot of the times their skin is so moist, their product won't stick well,
Mm-hmm.
and a belt. And
Okay.
if they're using a flat product, if they have the barrier rings, they could stack 2 barrier rings up right around the stoma,
That's good.
put a hydrocolloid dressing, the product, and the belt.
Makes sense. Yeah, that's smart to do the 2 rings. Awesome.
It's hard. What we do sometimes, because I think we're probably the only institution in America that has 20 wound ostomy continence nurses.
Mm-hmm.
So we do televisits with them. Sometimes they take off their product and we could see what's happening and tell them what to do.
Mm-hmm.
And Memorial's gracious enough that we Federal Express them emergency supplies 1 or 2 days sometimes.
That's awesome.
Really great.
And
Makes a
usually if
difference.
they're getting supplies from a company, if they call their supplier or the company, because it's always a middleman and the company who manufactures, one of those individual groups will possibly send a couple of extra supplies or samples to help them get through what's going on.
Oh, that's great. Thank you
Yeah.
so much for the talk. We have this available for people who hopefully will refer to this in the future when they're wondering what is going on with this ostomy consult, but it was really helpful to in person kind of get some tutorial on it. So thank you so
Thank
much,
you.
Christine. I
Thank
will
you for
see
being
you
interested.
on Tuesday.
All right. Have a great night.